Hello, good evening, everyone. Today's topic comes to you on the request of Dr. Preeti Mehta, a DNB student. I'm Muralidhar, Dean, Sikkim Manipal Institute of Medical Sciences and Professor of Obstetrics and Gynecology. Carcinoma cervix is a huge topic. In fact, the screening of carcinoma cervix can be a one-day CME. In that, colposcopy can be a half-day workshop. And there are lots and lots of recent advances that have taken place. To fit everything in a 40 minutes window, I have taken only salient points that are very important, both for the postgraduates as well as for the practicing obstetricians. I see that many practicing obstetricians are also logging in for these lectures. So to help them, I have made the whole lecture in such a way that I cover almost all the aspects in next 40 minutes. So issues that I address are risk factors and etiology, pathophysiology and clinical features, classification of precancerous lesions, staging of cervical cancer, diagnostic evaluations, management of precancerous and cancerous lesions, and finally, public health interventions. So let's take up risk factors and etiology. Early onset of sexual activity is squarely blamed on the onset of the cervical cancer. It is directly related to sexual activity. In a way, we can say that it is a sexually transmitted problem. Earlier, we thought that it may be due to sperms, but now we know exactly why the sexual activity is connected with this. It is HPV virus, beyond any doubt. Early age at first birth and increasing parity are again the risk factors. So anyway, luckily, Government of India has made the age for marriage is 21, but that doesn't mean that there won't be sexual activity before that. We have to educate young girls, teenagers, that sexual activity is directly related to cancer cervix, and earlier the sexual activity and earlier the first birth and increasing parity are the causes. Multiple sexual partners, a high-risk behavior is connected with the occurrence of sexual transmitted infections as well as the carcinoma cervix. So multiple sexual partners and high-risk sexual partner are again risk factors. Sexually transmitted infections, not just HPV, HIV, HSV, all these are connected. Vulval, vaginal, squamous, intraepithelial neoplasia. They also have the similar etiology. So if you have these, you can expect cancer cervix in some time or the other. Immunosuppression, as I just now said, HIV infection may directly cause or it can cause through immunosuppression. Low socioeconomic status, that is because it is somehow connected to sexually transmitted infections and occurrence of HPV, HIV, and all other, including early marriages, early sexual activity. So these are the risk factors in nutshell. Carcinoma cervix is not hereditary. It is not genetic. It is directly related to sexual activity. Early sex, multiple sex partners, early childbirth, increasing parity, and all sexually transmitted infections. Etiology, as I already revealed, and all of you know that, it is human papilloma virus. 99.7% of the time you can isolate or you can connect human papilloma virus to cancer cervix, not other way around. What do I mean by that? Just because one has human papilloma virus, they will not 100% or 99.7% get carcinoma. But if you take 100 cases of carcinoma cervix, you can somehow connect the dots towards human papilloma virus in 99.7% of the cases. That's the meaning. The highest ones are 16, sweet 16, 18, then whole lot of things. Intermediate risk are 40, 42, and then all of them. Low risk, which cause genital warts, 6, 11, 44, 55, and 74. HPV has tropism for immature squamous cells of transformation zone. So they somehow like these cells and they get into the cells, confuse the cells, and so that the cells will multiply in a bizarre way. After all, that is what is cancer all about. So they get incorporated into the cell nucleus of transformation zone, and then they confuse the cells. There will be high mitotic activity. Pathophysiology and clinical features. So this is how it is. HPV infection, 1000 into more common than LSIL. So the infection can actually go both ways. It can clear itself or it can progress towards LSIL if it persistent infection, repeated infection. Again, it can move towards HSIL or it can actually regress. That's what I meant by just because one has HPV infection does not mean that she will always get carcinoma cervix. It depends upon repeated infections, persistent infections. So the HPV infection can push a cell towards LSIL or it can come back after treatment if HPV is cleared. 93% by 3 years. Again, as I said, the latency incubation to cancer is 15 years. So 15 years of repeated infection, persistent infection is required for HPV infection to convert a particular cell into cancerous cell. So in between you get HSIL and that can actually regress. But once the persistence occurs, because the modifying factors like STD, HIV, smoking, and immunosuppression. These are the ones which will determine whether to push these cells towards cancer or push them back. So if the infection is STDs are not there, HIV is not there, smoking is stopped, and if there's no immunosuppression, even HSIL can go back. Else it will go forward. So annual progression of HSIL to invasive cancer is 1.4%. So also there will be some oncoproteins. They are E6 that binds P53 blocking apoptosis, E7 releases E2F from PRB driving cells into cycle. This is purely for postgraduates to remember. I have an option of not remembering this. Thank you. So clinical features, early disease symptoms, abnormal bleeding per vagina in the form of anything, postcoital bleeding, blood-stained leukoryal discharge, scanty spotting, frequent leukorrhea, serosanguinous, purulent, odorous, non-puretic. That is very, very important. So the main difference between the bleeding due to cancer and menstruation is that menstruation has got some pattern. It follows the hormonal cycle, but the cancerous bleeding does not have any pattern. There is no rhythm or rhyme. That's exactly why it can occur anytime. It's due to surface bleeding, postcoital bleeding, blood-stained leukoryal discharge, or any other type of thing, postmenopausal bleeding as well. Dyspareunia, if there is a big cancerous growth there, there will be dyspareunia. And of course, later stages, there can be pelvic pain when there is involvement of lymph nodes and ureters and others. Late disease symptoms, sciatic pain from lumbosacral plexus involvement, compression by the tumor itself, lower extremity edema. This is basically because of lymphatic obstruction, unilateral edema, typical of cancers. Hydronephrosis, that is because of ureteral obstruction. That means already it has gone to higher stages, stage 3B maybe. Urinary rectal symptoms, vesicovaginal or rectovaginal fistula. Now this can occur either because of cancer or because of radiotherapy, late complication of radiotherapy. And these vesicovaginal fistulas are very difficult to treat. Even if you operate, they will break down because you are dealing with fragile, friable tissues, and the tissues which do not have any supple tissues there, cells there, they are all fibrosed areas. They don't take up that easily. Now I come to classification of precancerous lesions. This is an important issue. Squamous cell abnormalities are classified by Bethesda system that holds now atypical glandular cells of undetermined significance, which we call AGUS. We don't know exactly what to do with them. I'll talk about that a little later when I talk about treatment in general. Then we have atypical squamous cells, not glandular cells, of undetermined significance, again, what we call ASCUS. Now, these two stages are reversible stages very easily. Whereas the next stage is low-grade squamous intraepithelial lesion, LSIL. This also is reversible. Then we have high-grade squamous cell intraepithelial lesion, HSIL. It may regress, but in the presence of repeated infection by HPV or existing infection of HIV, smoking, and other immunosuppressive activity, it usually progresses towards invasive cancer. Finally, we get squamous cell carcinoma itself, SCC. So cytologic features of SIL could be, as you can see here, normal, or then you can have bigger and bigger and bigger nucleus. And when it is HSIL, you can only see nucleus, no cytoplasm at all. This is a beautiful picture which shows non-dysplastic epithelium normal here, whereas LSIL, which is in the another classification, we can call it CIN1. In the older classification, older terminology, we used to call it mild dysplasia. So less than probably 1/3. HSIL has two things. Number one is CIN2. In the old terminology, moderate dysplasia, we used to say more than 2/3 or up to 2/3. CIN3 is also HSIL, which we used to call in the past as severe dysplasia or carcinoma situ. Carcinoma situ is no more used. And here it is more than 2/3, sometimes full thickness of the epithelium. And finally, we have microinvasion to macroinvasion. So this is a beautiful pictorial depiction of the new, old, and very old classification. The latest is LSIL. It was called CIN1. Before that, mild dysplasia. And HSIL has two things, CIN1, CIN2 and 3 as well. And in the older definitions, moderate to severe dysplasia or carcinoma in situ, and finally microinvasion. So what is the natural history or progression of SIL? So if it is LSIL, which is CIN1, it may regress in 60% of the cases. It may persist in 30%, of which maybe 10% go towards HSIL, not cancer. But HSIL, which is CIN2 and 3, only 30% will regress. Maybe CIN2 will regress. 60% will persist. Again, 10% will progress, but these are the ones which progress to carcinoma. Very simple equation here, 60-30, 30-60, and in both 10% progression, but in LSIL, progression is only towards HSIL, whereas in HSIL, progression is towards carcinoma. And for all of them, it takes around 10 to 15 years. So there is no need to panic. Just because a report comes as LSIL or HSIL, no, don't panic yourself first. Don't make the patient panic. Tell her it takes another 10 years. In these 10 years, we can do so many things. Screening methods, cytology, and cytology. This has been there. In fact, Pap smear. This is the first cancer which developed cytological screening by Papanicolaou because of the exfoliating cells. And this is the one which is easily available compared to other cancers in the body. I will talk more about that in the subsequent slide. Colposcopy, nothing like inspecting yourself. You become the pathologist in a way. You use magnification and diagnose different things. HPV DNA testing is the screening method now. recommended by WHO. I will again talk about this a little later. When HPV is the cause of cancer cervix, it makes sense to detect HPV DNA. Visual inspection of cervix, either by VIA, that is visual inspection with acetic acid, or VILI, visual inspection with Lugol's iodine, or VIM, visual inspection with magnification. These are mainly for low resource setting. Pap smear, what are the advantages? It's a simple test. We know that. Highly specific if you diagnose it, 95%. WHO suggests TED, not suggesting. One smear per woman between ages 35 to 40 in low-income countries will reduce the incidence of invasive cancer by 65%. WHO accepted this for a long time, but not anymore. I'll talk about that. So it said, if you did one number of years between the pap smears, let's say 1, 3, 5, and 10 years, if you did, the total number of smears would be per lifetime. After the age of 35, we are talking, isn't it? Because there is no need to do after the age of sort of 65 if all the pap smears have been negative. So you would rather do 30 smears if it is 1 year interval, and reduction of cumulative incidence will be 94. But if you did it once in 3 years, there will be only 10 smears, yet the reduction is 91%, which is not bad at all. And if you did once in 5 years, only 6 smears in a lifetime, and the reduction is 84%, which is not bad again. So you could do maybe once in 3 years, 10 smears in a lifetime is not too much to ask for. Disadvantages of pap smear, it's low sensitivity. Specificity is 95% okay, but sensitivity is poor. We do not want to miss any cancer, so it requires repeated smears. Always performed inadequately or inefficiently. You need to have special techniques. Now there are liquid cytology techniques, which slightly improves, but not really so much. Delay in reporting and need for follow-up. And need for lab and high human expertise. You need a cytologist, not just pathologist. Colposcopy. As I said, half a day workshop can be done on colposcopy, but I will just highlight the disadvantages today. Performed inadequately or inefficiently. Just because you attended one half-day workshop, you are not a colposcopist. You need to do repeatedly many times. Needs sophisticated equipment and high human expertise again. So in the low resource setting, both pap smear and colposcopy are not ideal screening tests for a low resource setting, for the obvious reasons which I said just now. You need a pathologist or a cytologist, and you need a colposcopist. Whereas VIA, VILI, and VIM require low technology, gives immediate results, and has higher sensitivity, is suitable for screening in LRS. All said and done. What does WHO say? WHO now recommends only HPV DNA testing and screening, because the lifetime risk of HPV infection is 70 to 80%. And in majority of carcinoma cervix, there is documented HPV association. I told you 99.7%. HPV screening should not be used for primary screening of women under 30 years. That is because, let's say, even assuming they started sexual activity at 20 years, you need nearly 30 years persistent infection. So that's 15 years of persistent infection. That's exactly why WHO has said, don't start HPV DNA testing before 30 years, because it regresses rapidly without causing any clinical significant disease. So the sensitivity is much better, not very good, but better than pap smear, 66.5%. Specificity is higher, 93.8%. But look at the negative predictive value, 99%. Something like NST. NST's positive predictive value is only 20%. Not great at all. But its negative predictive value is 100%. That means if NST is normal, baby is definitely normal. But if NST is positive, that means abnormal NST, baby need not be bad. Similarly, if HPV is negative, you can be rest assured that she's negative for cancer development. Most objective and reproducible of all cancer screening tests. So compared to even pap smear, this is better. Less demanding in terms of training and quality assurance. So most of the job is done by the machine. But of course, you have to have this equipment, cervical samples collected in a special transport medium and processed with hybrid capture to assay for 13 risk types. I am not sure whether it is good for low resource setting, but finally, we need to provide this for everybody. That's why WHO recommends. This is the latest WHO recommendation, July 6, 2021. For general population, screen and treat, or screen, triage and treat HPV DNA as a primary test, starting at the age of 30, every 5 to 10 years interval. Whereas for women living with HIV, screen, triage and treat only. There is no option. HPV DNA again as a primary test, but look here, starting at the age of 25, earlier, 5 years earlier, because they have an additional infection. They have immunosuppression. So the progression is faster. Every 3 to 5 year interval, not 5 to 10 year interval. So the progression is faster in them. So this is the latest WHO recommendation, July 6, 2021. PGs, please note. They recommend HPV DNA testing only. If you don't have that, of course, you can go for pap smear. People do combined testing, HPV DNA testing as well as pap smear, which is fine because HPV DNA test only tells that there is a possibility. But pap smear tells you that at what stage she is, whether she's HSIL, LSIL, invasive cancer. So pap smear is not out, pap smear is there, but the screening, triage, even for treatment, WHO recommends HPV DNA testing. So histopathologic subtypes of cancer cervix, when it is full-blown invasive cancer, squamous cell cancer 80% of the time. Adenocarcinomas 15% of the time. So rest of it is only 5%, not very important. These are the two main types. Adenosquamous 3 to 5%. Rare are transitional cell, neuroendocrine, small cell, adenoid cystic, mesonephric, adenoma malignum, lymphoma, lymphosarcoma. We had a case of lymphosarcoma of the cervix. So, but squamous is the most common one. Adenocarcinoma is the second one. Now I come to the staging of cervical cancer. A lot of things have changed in 2018, and I want to spend at least 5 minutes on this. FIGO staging 2018. Until now, the FIGO staging was only clinical examination. All of the cancers in gynecology, like ovarian cancer and even endometrial cancer, were all surgical staging. This was clinical staging based on clinical examination only. But the allowable components after 2018 are colposcopy, endocervical curettage, EUA, cystoscopy, proctoscopy, IVP, chest X-ray, additional modalities like ultrasound, CT, MRI, PET scan, and lymphoangiography. So FIGO Gynecologic Oncology Committee revised guidelines to allow imaging. That's very important. And pathological findings where available. And I've underlined that. It is not insisting that you must do this. They are saying where available to assign the stage. So if you have MRI, if you have pathological findings, then the stage will be different. But if you don't have, go ahead with the clinical staging and the minimum that you have, maybe IVP, chest X-ray, and an ultrasound. So I come to the staging. Carcinoma cervix is very simple staging. Stage 1 is confined to the cervix. Stage 2 and 3, both are talking about vagina and parametrium. The only difference is vagina is always A, that is first, and parametrium is B, that is second. I used to remember when I was a student as A is coming first, the gravity is attracting the cancer first. This is not true, but I used to remember that way. The vagina is A and it goes to lateral, that is B. So what's the difference between 2 and 3? 2 is not fully, 3 is fully. That's the only difference. Then 4, of course, is distant metastasis. Very simple way of remembering. But FIGO is not happy. They want students to remember complicated things. I'm joking. They are very particular that they have changed the staging because the treatment differs. How it is? Stage 1, strictly confined to the cervix, of course, that we know. Stage 1A, microscopic, maximum depth of invasion less than 5 millimeters. Here comes A1, stromal invasion less than 3 millimeters in depth. A2, stromal invasion is more than 3 millimeters, but less than 5 millimeters. Horizontal spread is not included. Earlier, we used to talk about 7 millimeters or 5 millimeters horizontal. Now we are only worried about the depth. 1B is macroscopic, that we knew, which is further divided into B1, more than 5 millimeter depth, but less than 2 centimeter greatest dimension. So after A2, it has to be more than 5 millimeters depth. But we are also talking about macroscopic lesion, less than 2 centimeters. B2, more than 2 centimeter depth now, and less than 4 centimeter greatest dimension of the macroscopic lesion. And B3 is the newcomer. B3 is the newcomer, which is more than 4 centimeters greatest dimension. Terminology about clinically visible lesions removed, depth and greatest dimension. This is the newcomer. I've encircled it. What is the newcomer? 1B3. Now, why is this important? What is the implication of this? Remember, in the past, we used to say anything less than 2A is operable. But what is the change now? Look at B3, more than 4 centimeters, bulky cancer, inoperable. I hope I'm clear. 2 is upper 2/3 of vagina. 2A without parametrial involvement. A1 less than 4 centimeters. A2 more than 4 centimeters. Now comes the situation here. We used to say, again, I'm repeating myself, up to 2A is operable. Now they have brought in A2. A2 is more than 4 centimeters. Bulky cancer, not operable. 2B, as I said, parametrial involvement, but not up to the pelvic wall. This is the change. What is the change? 2A is further divided into 2A1 and 2A2. 2A2 is more than 4 centimeters, inoperable. So that is the change. 3 is lower 2/3 of vagina and or parametrial involvement. 3A is without extension to lateral pelvic wall. 3B is extension to lateral pelvic wall. We know that. 3C is the new entrant. What is 3C? Again, it is divided to C1 as pelvic lymph nodes, C2 as para-aortic lymph nodes. Earlier, we never bothered about lymph nodes in the clinical examination. Now, with the advent of MRI and other things, you can include that, and a new entrant is there, added stage and proven or imaging or pathology P, previously nodal status didn't determine the stage. So this is the new entrant. Who is the new entrant? 3C. So totally, who are the new entrants? 1C, It was used to be 1A and 1B. Now 1C is the new entrant. What does it mean actually? Actually, it means, if I have to go back, that is, sorry, not 1C, 1B3. Earlier, we used to have only A1, A2, B1, B2. It is 1B3, means more than 4 centimeters. Then 2A is further divided to A1 and A2. A2 is more than 4 centimeters, inoperable. And in 3, they have brought in C. So C means you think of lymph nodes. 4, of course, not much of change. 4A is adjacent and B is distant organs. Bullous edema of bladder does not permit a case to be allotted to stage 4. It is stage 3B only. So these are the changes. I will repeat once again to avoid confusion. In stage 1, the new entrant is B3, which is more than 4 centimeters. In stage 2, the new entrants are A1 and A2, A2 being more than 4 centimeters. And in stage 3, they have brought in C. C1 is pelvic lymph nodes and C2 is para-aortic lymph nodes. There's no change in stage 4. So when in doubt, lower staging should be assigned. Lymphovascular space involvement does not alter the stage, but may affect the treatment plan. Extension to uterus corpus disregarded for staging purposes does not alter either prognosis or management. Nowhere uterine involvement is mentioned. Suspected bladder or rectal involvement should be confirmed by biopsy and histologic evidence. So diagnostic evaluations, per speculum is very important. Cervical lesion can be seen, exophytic, cauliflower or fungating growth, endophytic growth, barrel-shaped cervix, ulceration or papillary tissues, polyploid granular mass, fixed indurated cervix or necrotic tissues or friable mass, bleeding on touch, purulent or bloody discharge, vaginal extension can be clearly seen. So these are the things that you can make out by per speculum examination. Also, if there is fistula, you can clearly see. Pelvic examination, bimanual examination, you will feel that cervix is hard. You have to note the extension into vaginal wall. Uterus is enlarged if there is any pyometra, tumor invasion and growth. Enlarged and boggy, as I said, hematometra or pyometra. Per rectal examination is a must to know the consistency and size of primary mass. Parametral involvement, nodularity beyond cervix, sidewall involvement also can be made out. And rectovaginal exam, which will tell you about the rectovaginal septum between the index and middle finger, thick, hard, and irregular septum. The modalities for obvious tumor growth, take a biopsy. It could be 4-quadrant in the past, but now we do colposcopy guided biopsy. So colposcopic, normal cervix, dull and acetowhite patch because of the acetic acid will coagulate all the nuclear tissues. When you throw the light, it will reflect back. And thick plaque with sharp border, gray-white, grade 2, and dull oyster gray, grade 3. Whereas Lugol's iodine, you can see positive means, it will remain brown, whereas negative means it will just change because cancer cells will take all the glycogen. Colposcopy findings can be a wide variety of things. Today is not the time to talk about them. Cone biopsy is diagnostic as well as therapeutic. Remove the cone of the cervix involving the entire squamo-columnar junction, and then indications being unsatisfactory colposcopy or microinvasive carcinoma on biopsy, discrepancy between cytology and colposcopy, adenocarcinoma in situ. Positive endocervical curettage for CN2 and 3. So other investigations, HIV serology, CBC, anemia as usual, urine analysis, electrolyte imbalance, renal function test, liver function test, these are all basic ones. Sigmoidoscopy can be done to rule out the involvement in the rectum and in the colons. Cystoscopy to rule out the involvement in the bladder. Examination and anesthesia, sometimes the vagina will be so narrow, you will not be able to make out anything. X-ray chest, ultrasound, MRI, CT scan, PET scan also can be done. Now I come to the management of precancerous lesions. CIN1, observe with strict follow-up. CIN2 and 3, cone biopsy, LEAP or laser. CIN3 is simple hysterectomy if patient is not reliable for follow-up. Management of invasive cancer, stage 1A1, simple hysterectomy. Not associated lymphovascular invasion, completed family. Conization with negative margins and not completed family. Whereas stage 1A2 and B1, B2 is bulky cancer. Here, both surgery and radiotherapy are equally effective. Surgery is preferred in young to save the ovaries. Radiotherapy is preferred in older. Warthen's hysterectomy, the structures removed are uterus, plus minus tubes and ovaries, upper third of vagina, parametrium, and primary draining lymph nodes, parametrial, obturator, internal, and external roads. Invasive cancer, stage 1B2 or B3, radiotherapy is preferred irrespective of patient stage. Stage 2A, radiotherapy is preferred. Surgery should be considered only if the patient is young. 2B onwards, radiotherapy is the only choice. Public health interventions, primary prevention, stop smoking, use barrier methods, to prevent spread of HIV and HPV, postpone sexual activity, effective management of sexually transmitted diseases, and decrease the parity. Health education, HPV vaccination, screening, with all this, and carcinoma cervix has well-defined natural history, so we have some time before it progresses into cancer. Long detectable preclinical phase, easy accessibility of the cervix in settings where it causes major restraints, 30 to 40 years age seems to be an ideal time for screening. Thank you very much for your patient listening.